دكتور أيمن حمدان.
Just to check the picture whether it's running or not.
رامي. دكتور أيمن حمدان. دكتور مصطفى الجمال. دكتور عبد الله.
طفي
الدكتور عبد الله كساس موجود؟ لا. دكتور محمد نصر. فلسطين. والله فلسطين في كل مجموعة في فلسطين. وين محمد نصر يا جماعة؟ طيب. رامي موجود؟ طيب. أنا I think enough في الجلسة هذه 4 ولا بدكم كمان واحد؟ ها؟ دكتور عبد الله تحب تدخل؟ بتحب الكومبليكيشن أنت، تفضل. You like complication, right? Everyone likes complication. And I hope you find these cases very interesting.
Okay. Okay, thank you all. And we will start the session number 6, which is a complication session. We will start with Dr. Fadi Al Qaisi, intervention cardiologist from Jordan. When the cover doesn't cover, please, Dr. Fadi.
All right. Assalamu alaikum. The marathon end is almost there, 2-day marathon. This is a case I did in November 2022 during one of the visits to Cadillac Hospital. I have no disclosures. 63 years old gentleman presented with 2-day history of chest pain aggravated by exertion associated with nausea and shortness of breath. He's non-case of hypertension and he's current smoker of half to 1 pack every day. He is on only ibuprofen PRN. Those are the vitals upon presentation. Slightly hypertensive and there's systolic murmur. Blood test, normal kidney function, stable hemoglobin and negative troponin. This is his ECG, no significant changes. Echocardiogram showed AF more than 70%, no evidence of regional wall motion abnormalities. Normal right ventricular size and function, no significant valvular disorders. Impression was unstable angina, so we are referring him to the cardiac cath. This is his cardiac cath. We start with obviously normal left main. You have proximal moderate stenosis in the LAD, severe stenosis in the left circumflex artery. Moderate stenosis in the LAD that might be a little bit, because of the aneurysmal changes, might look a little bit worse than usual. And this is his RCA, diffuse calcified lesion in the RCA. My impression was 2-vessel disease excluding proximal LAD, and I decided for angioplasty. I decided treat the left circ first, so I did 2 overlapping drug-eluting stents with the use of Resolute Onyx 2.0 times 30 mm and Synergy XD 2.25 times 28 mm, post-dilated by 2.25 20 mm at 20 atmosphere. Then I approached the RCA, which I thought was more of the culprit lesion. I pre-dilated with a 3020 compliant balloon. I put stent Synergy 4.0 times 32 mm inflated at 12 atmosphere. And you can see that the stent did not fully expand. This is stent viz or stent boost for those who use Philips. And you can really see that the stent did not expand. And if we have time, we can talk later on, if we have time at the end of the case, the importance of imaging and plaque preparation. And that was discussion that we had yesterday. As usual, I said, under expansion, we have the solution for that. High pressure, let's go with the NC quantum. 40 times 20, we went up to 22, and I felt really happy that I expanded the stent, but my celebration did not last longer. Injection, and you can see there is wide perforation, and that was my impression. Who whistled there? Exactly. But so major perforation. I still have the balloon in my guide. We always test before we remove the balloon. Immediately I inserted the balloon back. It might be next time to test while the balloon is still there. So I reinserted the balloon to the location, and I inflated the balloon, controlling the bleeding. Then we have time to think. I called for the covered stent, and we have Perforation, the new generation of the covered stent, 4.0 times 20 millimeter, placed at the location that I thought the perforation coming from, inflated at 12 atmosphere. This was the images. I saw there's some bleeding. We took different views, looking closer, hoping that yes, we did things properly. I think the perforation is controlled. I removed the wire. I took another image, and the bleeding is not controlled. So, reinsertion of the wire. I said maybe the cover stent did not seal completely. So I put back the balloon, 4020. I put prolonged inflation, 3 minutes inflation, trying to control and make the stent covers all against the calcium. Another injection, still bleeding.
Did you reverse heparin at this time?
No reversal of the heparin yet. No. So obviously that was the process, and we said, okay, what we are going to do at this time. There is different scenarios in my head. What should we do? Where is the source of the bleeding? A couple of the scenarios I thought of, maybe the front end of the stent did not seal completely, and there is some tracking along the front, or the stent is not sealed properly on the walls, or the stent itself, the fabric. I don't have a long experience with this papers. Maybe the fabric itself is oozing through it. So the best option I could come up with while thinking on my feet was to put another covered stent. So I advanced a new covered stent, 4020 millimeter, inflated. And then at this time I thought, I got things under control, removed. We did multiple injections. You can see there is hematoma, but I thought active bleeding has stopped. And I thought that, okay, things under control. Let's take off the patient off the table. Next day, I checked on him. He has pleuritic chest pain, echocardiogram still showing EF 65-70%, no wall motion abnormalities, normal RV size, small pericardial effusion, no tamponade. I was like, okay, I'm lucky. I will take it, troponin 3000. This is his ECG. My impression was this is acute pericarditis with a diffuse ST elevation. Later in the evening, I got a call. The patient left AMA. He was a homeless guy in town. He left AMA. No medications. He just left, grabbed his stuff, and went. I said, okay, that's cool. So 4 days later, he showed up in the ER, intoxicated, alcohol level 207, chest pain, blood pressure still stable, troponin 1,700, trending down. It's difficult they are survivors, I'm telling you, they are survivors. This is his ECG showing some STT changes. And as echocardiogram showed moderate pericardial effusion, 500 ml, I drained 500 ml, echo still 65-70%, no regional wall motion abnormalities. Obviously, as most of you in the room, excited, what happened to the covered stents? So I took him back to the cath lab, and this is the image. It's still open, no bleeding, and nothing here. Then I took images for the other artery, the left circ is occluded. And here I had a tough decision. What should I do? Should I poke a wire, take it up, leave him alone? It's late presentation, he's 4 days, troponin trending down, no wall motion abnormalities, no chest pain. And I know that we have here like 50 plus people, and I know that I will get 50 plus opinions about what to do with this artery. My decision, I will leave it alone, I will walk away. I got bitten once, I'm not gonna do it again. And that was my case. Thank you very much for your attention.
Okay. Thank you, Dr. Fadi. Do you think that the bleeding, the start of the perforation, it was type 4, maybe?
Questions after the presentation.
Okay.
We'll postpone the question after.
Thank you.
Yeah.
Our next speaker is Dr. Yahya Ismail. He will be talking about distal, or he's showing us a distal coronary perforation. Dr. Yahya, the floor is yours.
Okay, can you show me, please, how to? Thank you very much. Allow me first to thank the organizing committee, particularly Dr. Mahmoud, who gave me this opportunity to present in this prestigious conference. Thank the panel and the audience. And I'm presenting this case on behalf of the cath lab team at the Najah University Hospital. So today, we'll present this case of distal coronary artery perforation, and we do it in two parts. First, I'm going to present the case, and then after, through the case discussion, we'll discuss the coronary perforation diagnosis and management. This gentleman is a 77-year-old patient who's a known case of hypertension and type 2 diabetes mellitus. He has multivessel disease, LAD 70%, diagonal 190%, circumflex 60 to 70, and RCA is 90%. And one might ask why this patient should not go through coronary artery bypass graft surgery, and unfortunately, half or over half of the patients nowadays, they do not go to surgery, either because the surgeon rejects them, if there is any surgeon in the room, or the patient rejects the surgeon. So one of them rejects the other. So this patient rejects the surgeon. So because we have team discussion and Dr. Yunus is here, we usually discuss those cases and make a decision and take the decision to the patients and make them decide. And unfortunately, as I said, most of them, they decide to go with PCI or catheter-based intervention. So this is the anatomy. And hopefully the second one will play, and it showed you the anatomy that I described earlier, and the decision was made for CTO or subtotal complex RCA lesions. And as usual, PCI intervention, two catheters was placed in preparation in case more complex retrograde and to see the distal coronary artery, and two wires passed through the distal coronary artery PLV as well as posterior descending. And many times with complex anatomy like this, and especially right coronary artery with a lot of calcium, you use Godzilla to help you to deliver distant or distal balloon and stents. And while you're doing this, sometimes you do not pay attention to the details of what's going on distally. And here, as you notice, one of the wires places itself unintentionally to one of the distal PLV branches, right? And as you notice here, if you pay, sorry, this is, oh, sorry. If you pay attention to this spot here, there is extravasation of contrast into this area. And now the question is, how should we treat this? Can we start with the panel, please?
I would personally...
Can you run it, run the slide? Let it run.
was that?
Yeah.
The wire, what was that? The wire? Filter. XT.
Yes. It seems not filter right now. It's not rapidly all the way. But before that, it was filter or something else. And this is the area of the distal perforation.
I would wait and watch it a couple of minutes. If you're done, I might pull my wire and reverse my heparin.
So for me, this is a tiny perforation. It's very distant. So if I can redirect that wire with another wire, not the filter.
Yeah, but as you know, the wire redirected, you mean to the branches which is perforated?
The branch and come across the perf side, and then try to put a balloon at low pressure, you know, at 8, 10 atmosphere pressure, and wait 2-3 minutes and see. If it does not, then I have two options. Either I coil that vessel proximal to the site of perforation, a small coil, usually we use Euro coil, or you put a grafted stent towards the distal, the more distal.
And what size stent do you think you would use?
It's a 2 to 5 colors. It's 2 5 stent. I think they come in 2 5.
I think this is the type of perforation that may bring you later with the tamponade. So I would do fat embolization.
Thank you. Right. I want to pick on you. Okay.
Of course, you have microspheres and other you know, fats, but these are usually.
First of all, the first wire actually is the CTO wire. It's called the XTA, and we have used and one the fracture this one. And usually with CTO, actually after we finish and before dilating with balloon and using extensive things, we exchange the wire and with the floppy wire, soft wire. Because this is what happens once you start pushing the balloon and the stent, the exit curve, it's not safe, and it will cause the exit perforation. You change the wire, but the perforation already has happened. Actually, in this situation, this is very small branch here, and this is the problem. It will not show immediately. It will show the CCU after 2 or 3 hours in the ICU. So this patient you should usually close it. And the way to close it, the easiest way is to go with the micro catheter and to send anything there, either fat line as Dr. Jammal said, or to just the thread and wire, surgical thread. You cut it in short pieces and you flush it there as you close it. This is the easiest, the cheapest way.
Or the soft tip of a knee and then you can take it.
Yeah, exactly. Anything, you stop anything else, because that branch is not important. Any foreign body unimportant.
I've been asking colleagues, anybody use... Anyway, this is what we elected to do. And so in this case, because it is distal, it is side branch, it is small, and here you have to take care of dual blood supply, because you have blood supply antegrade and blood supply retrograde, and we elected to use coils, and one coil deliver distal to the lesion, and the other coil delivered proximal to the lesion. And actually this leak was totally sealed, and the patient was completed the hospital course uneventful. Just for the sake of time, let me quickly review with you the coronary perforation, because it's unfortunate complications, but it can defeat the purpose of intervention and make your intervention failure. It can lead to morbidity and mortality, pericardial effusion, and cardiac tamponade, and actually death can happen. Luckily, death is rare in less than 1% of the cases, but if it happens with cases like Dr. Fadi, when it's widely open, the mortality can be much higher, right? And this is just a quick review to the studies that published in this regard. And actually, we have a good, decent number of studies and decent number of patients who had coronary perforation, and they've been treated with all kinds of intervention, include fat embolism, balloon inflation and weight, reversal of anticoagulation, coiling, and if it is in large branch, stent graft is typically, especially when we're not dealing with compromising major branch of coronary arteries. This is, I find, it's very nice algorithmic approach, and actually it summarized what we've said. They divided coronary artery perforation into many branch perforation and distal coronary artery perforation or side branch perforation, and they go through all the methods that mentioned. Dr. Abdullah mentioned actually inflation the balloon and leave it there for a few minutes, and hopefully this will stop, or fat embolization when it is distal or side branch, or coil embolization, and when it is in more proximal, especially not compromising side branch, stent graft is typically the method used to prevent bad consequences. With this, I will stop here, and I'll leave the rest of the time now or later on for discussion, please. Thank you.
Thank you, Dr. Yahya.
Thank you for this great presentation, and we will continue with Dr. Amr Alkarmi for spiral coronary dissection. Dr. Omar, please.
مساء الخير وشكرا كلكم لوجودكم هون. I'll start quickly. I've done this in public hospital. She's 77 years old, female, diabetic, poorly controlled, hypertension, poor compliant, hyperlipidemia, and she presented to ER with a 3-hour history of chest pain. Blood pressure 155/94, SATs slightly low. She's non-smoker, pain-free, troponin positive, and high CPK. We don't have quantitative troponin, it's either positive or negative. Her ECG, she was started on aspirin, Plavix, low molecular weight heparin, beta blockers, statins obviously, and echo showed anterior wall hypokinesia with normal valves. The plan was to take her to the cath lab on the following day. This is her coronary angiogram, the diagnostic. You can see the proximal LED. The circ is only minor plaque disease. Mid LED, hazy, calcified. And there is the osseal second diagonal. This is just picture to appreciate the calcium in that area. The right coronary artery, just minimal plaque. So the discussion was just to deal with the proximal LED, deal with the proximal and mid LED, or go for complex LED diagonal. My initial plan was to go to the proximal LED, but somebody convinced me to do the complex, which I regret after. So the plan was DK crush. And so I went with the wire to the LED, wire to the D1, D2, pre-dilated, and a lot of manipulation in that diagonal. The balloon is not inflating well. Very high pressure balloon inflations, up to 25, 26 in non-compliant. And this is just the wire. This is the balloon. It's just, you can appreciate, it's not inflating well. Okay. So my plan is just to look at that med LED after all the manipulation, just inflate a balloon, see whether the calcium will respond to me, and just stent and then deal with the diagonal afterwards. This is the balloon inflation, same balloon, I think it's 2.5. And this is what I got. Patient had severe chest pain. You can see the head move, which is not a good indication. Cardiac arrest, VTAC, 3 DC shocks, back to sinus, not intubated, but severe ST elevation in the anterior leads. I'm not sure that the monitor, but you can appreciate the calcium split just around the second diagonal with retrograde spiral dissection. Okay, so the second picture, obviously there's no pictures now. The second picture, I had no distal flow in the LED whatsoever. So I pushed a BMW, which went to a septal, and the only true wire, the only wire in the true lumen I knew about was the diagonal wire, because the proximally is actually in the true lumen. So I flipped it into and followed its brother, okay, and took a picture, and I'm not sure if both in the false lumen or one is in a true or one in a false. So I took the diagonal wire, original wire, flipped it because I thought the other wire is sealing the false lumen. Maybe I got lucky. And the rest is history. Just stented, okay? And those are the final pictures. And I left the diagonal alone. Okay, so iatrogenic coronary dissection, which I was looking at this, I was not aware of it. It's actually the recommendation. If you got absence of the true distal lumen, there is no cardiac indication for this, because actually what they said, that actually the cardiac surgeon, when they open, they will never realize the true lumen from the false lumen, so they don't know where they've grafted. So the only option, if you've got no distal lumen in dissection, is PCI. Okay, so if you got distal lumen, you can go with either. Okay, if it's involving the ascending, it depends how aggressive is that. Either you go with stenting or PCI. It depends on the scale of the dissection in the aorta. And this is the classical classification, but I think, as we discussed before, this is a very old one. The patient actually did well. She was discharged 48 hours. Afterwards, I saw her in a clinic about 3-4 months later, and she was doing well. And obviously after that, we lost all follow-up as the normal in our public hospitals. That's it. Thank you very much.
Go ahead.
So we can.
Let's open some discussions about the past cases. Yeah. Any questions in here?
Can I just say something here? It's Abdullah Shahab.
The floor is open to questions, Doctor.
Yeah. Can I just comment?
I have some teaching points for all speakers. I'll start with the first speaker regarding the perforation. First of all, when you are facing such calcification of the right coronary, very preferably to image the right coronary artery to avoid the complication, doing IVUS OCT, possibly need rota or IVL, and prevent such complication. Secondly, echocardiogram very crucial when you get perforation to know which type of perforation, type 3 or cavity spelling, because such perforation without hemodynamic collapse very unlikely to be type 3 perforation, possibly type 4, and we can wait and see. Thirdly, there's some tips and tricks when we are choosing a graft stent. First of all, the graft stent should be larger than the actual vessel size, 1.2 to 1. Secondly, should we go post the aggressive balloon dilatation for your graft stent, because the graft stent, there are some tips and tricks when you inflate. Inflate very slowly because it needs prolonged time to be fully opposed and possibly need another big size balloon to seal the perforation. This is for the second presenter when we are facing a distal perforation. In this case, this is LS type 2, which have a potential to be progressed for cardiac tamponade. So very probably to be closed. Fat embolization, recently, most of the studies do not support fat embolization because of high risk of granulomatous arthritis. Preferable approach, prolonged balloon dilatation, coiling, very important, or autologous clot from the patient, okay, to prevent further complication. For the case number 3, okay, this is spiral dissection. I think very preferably to be imaged the LID, because we don't know this is an actual spiral dissection, could be spasm, nitroglycerin, or putting the probe of IVAS looking for the dissection, and again provide a useful information about the actual size of the artery, because the stenting of the dissecting vessel, the strategies completely differ from the non-dissecting vessel. We need a lot of the stent, we need longer, at least 5 millimeter proximal and distal to be avoid any propagation of intramural hematoma. And thank you very much.
Yes, that's for the Dr. Fadi, for the main vessel perforation which you had. I'm not promoting to the graft master stent, which is the all 2-layered stent, but from my own experience and from what I saw and I heard from some colleagues, I think the efficacy and the efficiency of the recent grafted stents, the Bentley, namely the Bentley, and also the Papyrus stent, they're composed of 1 layer only. I'm not sure that the efficiency is equivalent between those the new versions and the old one. Although graft master, it is the putting and advancing a graft master is it's a larger profile, but I think it is more effective in sealing and getting opposed to the previous stent. So this is one of the
Dr. Adnan,
the other thing, Dr. Alkarmi, I think I agree totally with what you said, that this angiographic view is either a dissection or a spasm. So in this case, IVAS is mandatory because they give this similar angiographic views, and you can't tell which is which unless you do an IVAS, and you can determine, because this will definitely alter the management.
Short question to Dr. Fadi. Why you do intervention for this homeless patient who with high index of suspicion that he will not adhere to this medication? This is the first. And did you plan for this patient from the first image with RCA, with high calcium burden? If you plan, you can put an IVL for this lesion to, and avoid such perforation? Thank you.
Thank you for your interest in the case. Appreciate it. So we have 3 quick points. I'm going to cover them quickly so I don't take a lot of time. So first of all, treating or not to treat. As you know, we cannot discriminate against any patient based on their social status, and we cannot discriminate based on what they will do. We have a patient with non-STEMI or unstable angina, and he has to be treated to the top standards regardless of what they will do. Having said that, we have, all of us have tons of patients who might be very wealthy, very well educated, and yet they have horrible compliance, and we try to convince them. If we are going to apply the same rules that we are going to try because of the question of the compliance, we are going to go into a big spiral, big black hole that will suck all of us into. Second point quickly about the integrity of the stent, I totally agree with you. The parents, they have better instant restenosis compared to the graft master, which was the worst Achilles tendon for the graft master. The restenosis, they come back, whereas the papyrus they come with good long-term outcomes, but as you said, the integrity of the fabric
You
might
want
be
something to
questioned.
bail you out, yeah.
That's correct.
So the graft master would
And
be.
we have seen a few cases that actually the papyrus, if they cover side branches, some people they can puncture through it and
Yes.
pass equipment through it. That tells you how delicate they are. That's why I went for the second one, thinking that was one of the processes that might happen. And having the choice of the stent, that was unfortunately the longest one I had on the shelf at that time. I wish I had a longer one to seal the inflow and the outflow altogether, but I'm not sure about the sizing. That was maybe going to a 4-5 balloon rather than a 4-0 balloon would have a great idea, but I did not try it. I cannot comment on that. The last point about which is I'm going to spend a little bit more time, and I hope as a group, because over the last 1 year after that case and a few more cases, my approach of plaques and treating arteries have shifted, has matured to another level, which is instead of treating stenosis, is to treating an artery and plaque modifications. I totally agree, because yesterday we talked about the need of the IVUS pre and post, and why do we need IVUS? Having said that, this was a great case. If I had time to go back in time and do this case again, I would have imaged before, I would have learned about the plaque burden of that one, and I have done plaque modifications by breaking the calcium either with IVL or rota, instead of leaving calcium spikes with strong muscles post-dilatation poking through the artery and causing the major perforation. I believe I would have done better and served the patient better instead of leaving him with 3 layers of stents by doing a little bit more spending time IVUSing, OCT, learn about the plaque and modify the plaque properly. And from that case, I had other cases that I started whenever I doubt. Actually, we have a case coming this Monday that I'm calling both companies, Rota and IVL, so I can choose which one I'm going to use for my patient. Having said that, that will run us to, I'm sorry if I run. I'm sorry for the last point is cost. Our biggest comorbidity in Jordan and the Arab community is self-payer. That's a comorbidity, self-payer. We try to cut shortcuts to save on the patient. IVUS is not available for Dr. Alkarmi in his Hamza. So that's very important. Like, we can talk all the science, but we have to be practical, and obviously all of us face the same problem.
Thank you, thank you. We go back to Dr. Al-Jammal, please.
طيب, as a panelist, to say first one word about حالة Amr Alkarmi before closing the discussion, because there was a staining of contrast in the middle of LAD. That was dissection rather than spasm. This case, which I did maybe 5 years ago, I wanted to share it with you, and maybe I don't recommend anybody to do it. It's about 57-year-old male patient, smoker, known to have HOCM, with only mild LVOT dynamic obstruction. Was admitted with prolonged chest pain. On examination, he had a stable vital signs. His EKG showed left ventricular hypertrophy and strain. His troponin was negative. In fact, he was admitted over 2 months 3 times. Every time because of the angio, I'll show you. لا كيف بدنا نشغل الانجيو؟ طب شغل لي الانجيو. As you see, the flow in the LAD decreases during systole in the middle AD, and you see that there is a long lesion. Next. من عندي تشغلها. والار سي اي كان في نون اوكلوسيف mid RCA disease, and it was dominant. Next. He was discharged on beta blockers, and he came back after another 2 weeks with chest pain, and he had troponin negative. Then he was readmitted 3 weeks later with chest pain, and he had stable vital signs. EKG, there were no new changes. Echo, Hockham with mild LVOT obstruction. His septum was 2.8 centimeter. Now this time his troponin is positive. And شغل. Now this is his angio. There is a bridge in the middle AD. Next. شغل. Okay, next. So I tried conservative medical treatment with it, but it didn't succeed. So I decided to test the vessel. I thought there is a burden of atherosclerosis, and I said, let's test the vessel with the subnominal angioplasty to see whether I get better diameter. In case of bridge, of course, I will not. So I tried. There was improvement in the diameter. Next. Okay, next. I deployed the first stent, and this is the second stent. Here there is a waist that doesn't give up. Next. Here when I dilated between both stents. Next. There was a perforation, but fortunately and luckily it was to the cavity rather than to the pericardium, so I created a fistula. And evidently it was a large fistula. So I decided to cover it with the covered stent. First I localized with a balloon the site of where I intend to deploy the covered stent. It's here. So I pulled back the balloon, and at the same site I deployed a covered stent.
This is a graft. Double layer. Double layer. It looks like a double layer.
والله ما بعرف شو اعطوني اياه. It's a covered stent. شايف؟ شغلها. يعني هون the large fistula was replaced with a tiny trivial fistula, but no perforation to the pericardium, and this was the final result. Thank you.
So we can start a discussion and question, please, Dr. Haytham Shouli.
Can I just say, so it's a great session. Normally we have, this kind of meetings when it's about complications. It's really, I think it's a great opportunity for us to share our experience rather than to speak about the theory, because everyone knows the theories. We all know algorithm. So I really like, that when the people talk about what they've done, and then we can focus on that aspect, because I've seen, one of the presenters talked about the fat. Well, that's great. I know there is not much data on that, but let us share that. Let's focus on that. Going in other aspect of how manage that perforation is easy for us to, we can do it. I think this is an opportunity. We do it for 2 days in our GIS, and really we focus on that, because that's why we, in your lifetime experience, how many complications you will get? A handful. But in this kind of meetings, you get like 1,000 experience, from all that. So let us focus on that. So my question about the first case, the lesion tells you, look, don't touch me. That's the right coronary. You just calcified, unless you have the appropriate tools, And of course, everyone's talking about imaging. So where's the imaging here? Everyone talk about imaging. That's where the imaging should be done. Otherwise, you don't stent that area. You do what you can do if the patient in pain. Otherwise, just leave it and send it to another place. I know it's easy to talk about this, but this is for prevention. When it comes to complication, I think you've done a great job. Thanks.
Okay.
I have a question one comment for Dr. Fadi about his case. Your case is interesting, so there are more and more questions. Just when you want to bring the cover stent to place, I think we should perform ping-pong technique in order to allow us more time with inflated balloon and preventing more extravasation and keeping the patient hemodynamically stable. This is the first. And about the last case, I think there may be a distal atherosclerotic lesion, but the second stent, the first stent, the distal stent was there, but the second stent was in the bridge segment. So I think that was the reason for the extravasation. Not extravasation, for the fistula that you performed.
So stenting bridge is not absolutely contraindicated. It's relatively contraindicated. If there is evidence of ischemia, either by nuclear, echo, or whatever, then you have to revascularize. If the patient is having recurrent angina, you could do a lima for this case, or you could put a stent. But usually stent, because of the shear stress, they do restenosis. So that's why it is preferable, if there is evidence of ischemia, recurrent angina, to send the patient to surgery rather than stenting. One may say that I can give him a choice. I put a stent. If it restenosis, then I would come back and send him.
Yeah, but the main problem was the patency of the grafts and the surgery in the situation.
This is very distal muscle bridge. Would you stent it? Would you change your management? Very distal muscle bridges. Very distal.
Very distal muscle bridge.
Very distal, and it's long one, and it can cause systolic stenosis more than 80.
And you leave no.
Would you stent it?
In my experience, we had like hundreds of bridge patients. I never stented anyone. Anyone of these.
So the message for the audience, because we learn from each other's.
Yeah.
When you have muscle bridge, it is.
I want stent.
Better not, especially when it is long and very distal. So.
بس هو دكتور مصطفى عشان.
Yeah, it is a great safety.
Yes. It was. طبعا أكيد هلا يعني bridge implies intramuscular course of the artery, and that could be a band of muscle, or it could be a tunnel that is shallow, less than 5 millimeter, or deep, more than 10 millimeter. I think that we need CT to see the configuration and the site of the bridge before intervention, if you decide to intervene.
Dr. Mustafa, I don't think you should stent this at all, even if he is symptomatic. This is hypertrophic cardiomyopathy. He's going to have a very sustained pressure in a long, deep intramural stentings. Restenosis high, early restenosis high, stent fracture high, stent thrombosis high, perforations high. And you did perforate, and you perforate in the cavity. I don't know whether you need to do a graft stent on that. You perforate in the cavity. Unlike Dr. Fadi, I disagree with my colleague there. This is a type 3 perforation, otherwise he would not have tamponade Dr. Fadi case. This is a true spell out with hematoma and staining. In addition, hypertrophic cardiomyopathy tend to have multiple tunnels, not only one tunnel. And this is a deep, long intramural bridge. We probably should stent. Stenting is preserved Actually, medical therapy is superior to stenting. Stenting is preserved for only highly symptomatic refractory to medical trauma who are not optimal surgical candidate. يعني حتى surgery comes before stenting. And surgery, by the way, Dr. Abdullah, is not lima. Lima would occlude. Surgery is myotomy and unroofing. Otherwise, if you put just lima, it will
occlude, Dr. Asim. But there are reports that the bridge will recur after the lima anastomosis.
No, 50, I think this has been studied. This has been studied. 50% of limas to bridges will occlude because of competitive flow. They will not stay open.
The concern is more with the recurrence of the bridge post anastomosis. There may be some
generally
the other thing
competition, but
for Dr. Mustafa, I know almost if you decide to treat bridges, you have to treat the proximal or the inlet of the bridge, because most of the time, more than 90%, this is a diseased segment that even different from the tunnel segment that you have to include it in your treatment and extend your stent proximal.
Generally, nowadays, it's not recommended, and this is by expert opinion. Unfortunately, there are no large-scale studies to compare medical cabbage or PCI in case of bridge, but it's not recommended nowadays. It's not recommended to stent bridges because of a fracture, increased incidence of instant restenosis and perforation. And this is expert opinion. In my case, the atherosclerosis burden was distal to the bridge.
Yeah. There is
more
no,
than
if
the
you want
proximal.
to do surgery, now everything is like a metallic jacket. Where are you going to do your...
Not now, I'm talking about surgery. Now is not an option. The other point I want to just make a comment is Dr. Yahya case. In contrast to our general belief, wire perforation, they rarely seal by its own, and you have to treat them, as Dr. Raid, on spot. Because if you with them, they continue to ooze slowly, and 6 to 8 hours, your patient is going to tamponade. And since it was distal, I think that what was done is appropriate by coiling that small artery and not waiting till the patient tamponade later on. Thank you.
So Hokum and bridge is really a complex case, isn't it? I mean, to have two together. The problem is just this comment. I'm saying Hokum and bridge is really, it's a special case, and especially if you want to PCI, that segment where the hypertrophy is, it's very difficult. I think.
Even Dr. Mustafa, he regrets stenting.
It's a nice case.
So I think the message, thank you, Mustafa, for showing really this complication.
Yeah, but I think the
message
imaging
is very clear not to stent muscle bridge.
Okay, and I think I want to thank you for the guys who shared us, the colleagues, because I think from the atmosphere, this is what creates more discussion. This is what we learn from, and I think we need to congratulate all of them of taking care of these complications and sharing them with us.
Absolutely.
And maybe next times we need to encourage more sessions of these, because to tell you the truth, this is the way I'm going to change my practice. Theory is, as as our colleague said, it's available on Google. You can Google any theory you want. But these things, sharing is the way to.
Thank you.
My question to Dr. Haytham is, for educational purposes, tell us about the ping-pong technique in applying the grafted stents, and then Dr. Yahya, if he tells us why he didn't apply a small balloon inflation, long balloon inflation, before going to the course.
Thank you for the question. The ping-pong technique is coming with another axis, keeping the first balloon in the first axis inflated, and just getting the catheter out of the ostium of the right, in this case, in the right coronary artery, and coming with the other catheter from the other axis, and engage the RCA, going with the wire until you reach the balloon, slightly deflate the balloon, pass the wire, and then inflate the balloon, come with the cover stent, and then deflate the balloon, deploy your covered stent, and then you have time. It allows you more time to bring the covered stent.
This is to shorten the exchange time.
Yeah,
right. It's a dual guide. Dual guide use.
Because coronary blood flow is a high flow, so with 1 minute you may have an extravasation of 300 cc of blood, and it's a huge amount as if it's acute, because it's an acute extravasation in that chronic situation. So even small pericardial effusion can compromise the heart, can cause tamponade. In this case,
we did a case yesterday actually for the two catheters in the left main, and it is the same concept.
Traditionally, the dual guide was reported in cases of perforations, just to shorten the exchange time, because you'll spare like 1, 2, 3 minutes while retracting the first balloon and then advancing the other. You bring another guide. Nowadays, you're using that in ipsilateral, contralateral CTO retrograde cases.
Yeah, but actually, if you have type 3 perforation, we have to say, as Dr. Haytham said, the bleeding is severe, and you can't deflate the balloon and take the balloon to do an exchange. In this situation, you have to inflate the balloon, wait the time, prepare yourself, prepare your surgeon, do the echo to see that if you have a pericardial effusion at the same time, yes or no. Maybe prepare blood for transfusion. You have the time to prepare everything at that time, because if you take the balloon and just come with the cover stent, during this 30 seconds, the bleeding will be severe. We know that the blood flow in the coronary artery is about 20% of the cardiac output. If you have a cardiac output of 5 liters per minute, the coronary flow is more than 1 liter for 1 minute. The LAD, it will be more than 500 cc every minute.
How about the pericardiocentesis and the autotransfusion?
Yeah, you can.
Dissection, and this is very important.
Yeah, this is very important, and because of that you need the ping pong technique.
But there is a very important point in this ping pong or dual angiography, is that you should take care that at any second, at any moment, that only one guide is deeply intubated. So you should alternate. Yeah, you should not intubate the ostium of any coronary simultaneously with both guides. Otherwise, you can get ischemic.
It's good in the RCA. It's okay in the RCA, but in the rest system, it will be difficult. Sometimes you can engage to the right, and you will reduce the blood. You can reduce the blood flow. You have the time. You have 5 minutes, 10 minutes, 15 minutes of ischemia, 20 minutes of ischemia. But if you have a tamponade for the patient, it will be life-threatening. So I think that even a slight ischemia will be good.
If I can just mention, and what we've just mentioned now, the whole ping pong technique. That's now the standard practice, by the way. This is not the unique thing. This is what we should do in all perforations. It's called block and deliver. The whole concept is you're blocking the outflow from the perforation while you're delivering your equipment. So actually, it's what we should do for all perforations. I don't want to be, this is now standard. This is not unique. This is not special. This is the standard technique now for all perforations. You see a perf, you put your balloon, you inflate. Khalas, you've got time. You get your second access. You might already have a second access when you're doing CTOs. Because all CTO operators now do this all the time. You get your second access, you get your wire down, you deflate, you put your wire down, you inflate again. So you're deflating, you're allowing flow through that perforation for seconds. And so it's not dangerous. It's actually the safest way to do this. Berlakis has prescribed this beautifully in his book.
Excuse me. I want to add some things about recently published in JAC 2022 December regarding the treatment of the muscle bridge. There is very interesting algorithm for treating the muscle bridge and resolve all debate and conflict about how we can manage muscle bridge. First of all, an asymptomatic patient should start medication, high-dose beta blocker, maximally tolerated beta blockers plus statin. The patient persistently symptomatic should be go to evaluate by IVAS, OCT, and FFR wire, looking for the physiological hemodynamic significant or not. Significant should be managed, looking for the length, depth of the muscle bridge. length more than 20, depth more than 5 millimeter. It's indication for surgery. Limal ID, there is some concern about competitive flow. Recently, SVG might be more superior than the limal ID in grafting the muscle bridge. Secondly, if the length less than 20 millimeter and depth less than 5 millimeter and the patient symptomatic despite of indication, the best way is removing surgery. Regarding the stenting, there is very interesting study recently published regarding stenting. It's indicated for the muscle bridge, provide many things. First of all, using second generation stent, IVUS, pre and post, to avoid oversizing, undersizing, and avoid the complication with perforation and ISI.
Thank you. That will
Thank you
end
very
our
much
session.
by
Thank
doing
you.
this. Thank you.
Okay, thank you.